Well, welcome everybody to Clinical Grand Rounds and Optic Neuropathies. You got some nerve. We have a lot to talk about. So rather than go any further, why don't we just get started right now? Now, my disclosures in the past 12 months, I've lectured for, consulted with, or advised the company's advices, Zeiss and Bausch and Lomb. I've got no financial interest in any products we may discuss. I am a co-owner of Optic Education Consultants. Now, the first person is a 28-year-old female who presents with intermittent blurred vision and visual gray outs, intermittent horizontal double vision, and chronic steady headaches for about 2 weeks, which have been worsening. Her medical history is significant for white coat hypertension. She gets nervous among doctors. She has a shoulder injury about 6 months. She's using muscle relaxant. Her height and weight is 5'3", 220 pounds. She is 20/20 in each eye. Her pupils and motilities at the visit are all actually normal, although she might have a little bit of an ESO posture, and she looks like this. And we can see bilaterally elevated optic nerves. We see some juxtapapillary folds in the retina. And we have to, ask a number of questions. We're probably going to have to do a number of tests. And that brings me to polling question number 1. So I'm going to launch that for you. What is the next medical test that this patient needs? Is it an MRI? Is it an MRV? Is it a CT? Is it a lumbar puncture? Now, if you want to move your poll, you can left click and drag it out of the way and see the background. That's actually the Mendenhall Glacier, and that is in Alaska. So what medical test does this patient need? MRI, MRV, CT, LP, or maybe even something else. Okay, we're doing very well. So what I'm going to do is I'm going to end the poll. I'm going to share the results. Large number have said lumbar puncture. Other people say MRI. Some people say MRV. Some people say CT. And to a certain extent, all these tests are actually very valuable. Another test to always consider, which we didn't put up as an option, is blood pressure. Really, whenever you see bilateral disc edema in any patient, you should always check the patient's blood pressure to make sure they're not dealing with malignant hypertension. So on additional history, she has a dull ringing in her ears, not really kind of a tinnitus, but it's kind of dull. Her blood pressure is 142/100. Biomicroscopy, she's unremarkable. Applanation, she's got 16 pressure. Visual field, bilateral blind spot enlargement, and a little bit of a nasal step in each eye. Serologically, she was normal. She did undergo imaging. She had small ventricles, otherwise normal, no mass lesions, no hydrocephalus, no hemorrhage. Ultimately, she went under a lumbar puncture. Her opening pressure was 510. All CSF studies were normal, and she was diagnosed with pseudotumor cerebri. But realistically, she actually manifested at first papilledema, which is a clinical suspicion, but not really a clinical diagnosis. There are various signs and symptoms. Signs: bilateral disc edema. Bilaterality is the rule in my entire career. I've seen exactly one patient with a brain tumor who had unilateral papilledema. And like glaucoma, it's going to affect the superior and inferior aspects of the optic nerve first. This is the most prone area. The blood vessels are going to be buried. They're going to be obscured. They're going to be obliterated. Eventually, they will lose the perception of the cup. Hemorrhages are common early on. There's typically no spontaneous venous pulsation. And those Patton's folds, those advancing and regressing areas of edema, is very suggestive of true papilledema. Now, the visual field defects can be highly variable. Usually we start with an enlarged blind spot, then we start to develop glaucomatous-like defects such as arcuate defects. But in late stage disease, when the disc is becoming atrophic, you're going to have very constricted visual fields. There's no afferent defect nor typically because it's symmetrical, and acuity is typically very close to normal. Now, symptoms. Transient visual obscurations, not blackouts, but grayouts. They can happen 10, 20 times per day, and they only last a few seconds. Now, if a patient were to bend over, tie their shoe, pick something up, have their head, below their waist or below horizontal, it would precipitate one of these obscurations. They often have intermittent horizontal double vision as a result of a either unilateral or bilateral nerve palsy. Headache is very common. Nausea and vomiting can occur. Nausea or vomiting without nausea. And when people vomit, the floor of the fourth ventricle is the vomit center. As that expands within a hydrocephalic state, patients will vomit. Vomiting leads to dehydration. This is the body's attempt to rid itself of increased intracranial pressure. And dizziness and tinnitus can also occur, though it's not quite as common. Now, papilledema can be acute, it can be chronic, or it can be atrophic. Acute, as we see in the lower left, is very, very hyperemic, very hemorrhagic. You may see some exudates. You may see a very hyperemic nerve. There's often some juxtapapillary neurofibrillary edema. In the chronic phase, which we see in the middle, there's minimal hemorrhage, minimal exudate. It really isn't as hyperemic, and collateral vessels may be present at this stage due to the venous congestion. The atrophic stage, which we don't want to see, is in the lower right. And this is what's going to happen eventually if the disc edema remains too chronic. At this point, the nerve becomes pale, the visual field is constricted, and one thing you may notice is it is not really swollen because dead things don't swell. You lose the disc swelling as it becomes atrophic. Now, this disc edema is coming from axoplasmic stasis. You've got the increased cerebral spinal fluid pressure that's being transmitted down into that optic nerve subarachnoid space. And this is leading to a regurgitation of metabolic byproducts at the level of the optic nerve. So this is what's going to result in this engorged, swollen optic nerve. Now, papilledema can occur due to various intracranial abnormalities. Increased brain volume from a mass lesion, as we see right there. That's a huge lesion causing a midline shift. Intracranial blood volume, we can see that there is a hemorrhage here, and that can increase intracranial pressure. Or increase cerebral spinal fluid volume, which you see in the lower right, the hydrocephalic state. Now, you don't need to have a huge brain tumor in order to cause increased intracranial pressure. A smaller lesion can actually block the flow of cerebral spinal fluid between the aqueducts and lead to a hydrocephalic state. A patient I just got imaging back on from last week had a very significant brain tumor, but it was also impinging on cerebral spinal fluid flow, leading to hydrocephalus. So in this situation, the patient had both hydrocephalus and a mass lesion, and interestingly enough, did not have papilledema, had very constricted visual fields. Now, when dealing with papilledema or suspected disc edema, we want to rule out the masqueraders. We want to rule out the disc drusen, the congenitally full optic nerve, the high hyperope, the just very small crowded nerve. And we're going to be looking at the color, the margins. We're looking for the irregularity of disc drusen. We're looking for any possible obscuration of vessels, particularly superiorly and inferiorly. You want to look for spontaneous venous pulsation, which is not always the easiest thing to see, and not always that common. And of course, you want to look at the branching pattern. Sometimes these vessels have not a bifurcation, but a trifurcation, an abnormal branching pattern, telling you more likely than not it is actually an anomalous nerve. Now, acute papilledema can be considered a medical emergency or certainly an urgency. We need to get neuroimaging to rule out a mass or a bleed. And sometimes going through the emergency room is the most expeditious way to do this if you're willing to help them. Now, if the imaging is normal, oftentimes they'll do a lumbar puncture to measure the CSF pressure and also analyze the cerebrospinal fluid to make sure there's no infective process, no meningitis. Atrophic papilledema, significant vision or field loss, well, we have to move very quickly because they need urgent measures. They're going blind. So we actually have to be kind of quick on this as well. And papilledema or suspected disc edema or suspected papilledema, accompanied by any neurologic abnormality such as a fever or stiff neck, this tells you we may have an intracranial infection, and it's going to require immediate medical attention. Now, please don't think that simply sending a patient to the ER, the right thing is going to get done. It's not. If a patient goes to an ER and they have a visual-related problem, more likely than not, they will do a non-contrast enhanced CT of the head. And if that's normal, they'll often release the patient and say, follow up with an eye doctor. And that's really not the right thing to do. Now, pseudotumor versus IIH, idiopathic intracranial hypertension. A lot of people are under the misconception that IIH is the 2022 term or 2020 term, the current term to use, and that pseudotumor is actually an older term. That's not actually true. Pseudotumor really means increased intracranial pressure, but there is no mass lesion. That's all it is. There's increased pressure, no brain tumor. But there have been other causative agents that have been identified. Venous sinus thrombosis. And that's why the testing for this involves MRI and MRV. State-of-the-art, standard of care testing for a suspected papilledema, MRI and MRV, looking for venous sinus thrombosis. Now, hypervitaminosis A, vitamin A toxicity, oral contraceptive use, oral tetracycline use. These have all been associated with pseudotumor. When any of these are present, exogenous medication use, it is called secondary pseudotumor. Now, there is a subset of increased intracranial pressure, but there's no identifiable cause. There's no venous sinus thrombosis. There's no infection. There's no exogenous medication use. In this case, we call that then IIH, or idiopathic intracranial hypertension, also known as primary pseudotumor. And this is the young, obese females who tend to be at risk. And everything is coming down to poor cerebrospinal fluid drainage. It's like glaucoma. It's not that there's too much being produced. It's not enough being drained by the arachnoid villi. So pseudotumor is still the best term. It's encompassing. Secondary pseudotumor or primary pseudotumor, and primary pseudotumor is IIH. Now, diagnosing pseudotumor, we want signs and symptoms consistent with increased intracranial pressure. There should be papilledema, and it may be subtle, very difficult to diagnose. And they have to have a normal neurologic examination. Everything has to be fine, no Horner syndrome, no ptosis. The only thing that they're allowed to have are cranial 6 palsies. And the reason why we have cranial nerve 6 palsy, is when the intracranial pressure elevates, it forces the brainstem to herniate down through foramen magnum. It stretches the 6th nerve off across the clivus and give a unilateral or bilateral 6th nerve paresis. Now, neuroimaging has to be normal. Can be no hydrocephalus, no mass lesion, no blood, no structural lesion, and no venous sinus thrombosis. And the CSF has to be normal. Now, ultimately, these patients often will get a lumbar puncture. Easy to do, hard to obtain sometimes. In adults, they're going to be over 250 millimeters. Children over 280, that's very diagnostic. Now, lumbar puncture often is being deferred. Now, it's not meaning that they're getting bad care. First off, if the MRI and the MRB shows no additional abnormalities, and the MRI does actually have some characteristic findings. One is flattened globe. You can actually look at the globe, and the back of the globe are flattened. And the sella turcica appears empty. And the reason the sella turcica appears empty is the pituitary gland, which is in there, is very gelatinous. The increased cranial pressure kind of squashes it down. There could be no evidence of fever or acute infection if it's, a younger, slightly overweight female. Well, a lot of times lumbar puncture will not be done. And it's not bad care. It's just default. We have a lot of good findings to support pseudotumor. Now, managing pseudotumor, if there's no visual loss, they're treated with symptomatic headache therapy and acetazolamide. Now, 500 milligrams 3 times a day or twice a day for a prolonged period of time is fatiguing. The malaise and the side effects that some of these patients get. Now, the younger patients tolerate it better than the older patients, of course, but it is a tough medicine to use long term. And it is actually an induction or inducement for the patients to undergo the definitive treatment, that's weight reduction. And the weight reduction needs to be about 10% of the body weight. Now, I've seen as low as 5 or 6%, but 10% is going to be the most effective amount. If they have mild visual loss, acetazolamide, 500 milligrams 3 times a day, can be replaced with furosemide, topiramate, sinistamide. Topiramate is actually an anti-seizure medicine that has some weak carbonic anhydrase inhibitor properties, as well as it manages headache and it helps with weight loss. So these are all possibilities. Now, the prognosis is actually pretty good if they got very mild vision loss. With treatment and weight loss, everything should really follow up or resolve in about 6 to 9 months. But here's where we really need to be involved is you need to follow these patients with OCTs, photographs, and visual fields. Very important. I'll explain why in just a bit. Weight loss, very important. It's treating the primary problem, about 10%, and they have to keep it down. A number of these patients that I've encountered have presented with increased with weight gain and increased headache. And other patients that I have encountered, they have reported they lost a few pounds and their headaches got better. Now, here's a nice example of a young patient right here. We can see she's got bilateral disc edema. We have obscuration of some of the major vessels. It is bilateral. It is not hemorrhagic. So this tells us we are probably looking at somebody who has had this chronically. We can see that there is some degree of blind spot enlargement. On the OCT, it is the juxtapapillary edema is so profound that it is really off the scale. And on the serous, we call this the patriot sign as indicative of increased juxtapapillary nerve fibular swelling. You see it's red, white, and blue, the patriot sign. Here's a nice example. 33-year-old female complains of horizontal double vision, and she does have a subtle sixth nerve palsy. She's got headache, chronic, daily, and transit visual obscurations about 20 times per day. She denies oral contraceptive use, no tetracyclines, no vitamin A use. She had lost about 10 pounds recently and noted that her headaches had gotten better and her blood pressure was in a normal range and her BMI was a little bit under 27. And this is what we see here. We have bilateral disc edema. We can see obscurations of the major vessels, probably some Patton's folds, no degree of hemorrhage or exudation. So this is probably somewhat chronic. We can see our Patriot sign here on serous OCT, a little bit of a superior arcuate defect in the right eye with a enlarged blind spot, a more significantly enlarged blind spot in this eye. She underwent neuroimaging, MRI, MRV. She had, I think she had LP done and it was elevated, no sign of infection. So she was diagnosed with IIH or primary pseudotumor. She was put on a course of exercise, weight reduction, and Diamox therapy. And this is what happened to her between follow-ups. These are her first visits. These photographs are about 3 months later. And we can see that there is some reduction of the edema. Now we see in the visual field, there was a little bit of an arcuate defect, has now seems to have reversed or disappeared. And this is a patient who is getting better. Now, here's the importance of these tests and photography. First off, once the patient's downstream, none of this will be done again. Neurologist is not doing this. The internist is not doing this. Emergency room physicians are not doing any of this. Now, if I just look at this photo right here, I say to myself, there's disc edema. If I look at the optic nerve 3 months later, just looking at the nerve, I say, there's disc edema. Is it better? Yeah, because I've got photographs, and that's where it's important. Photography is very important. Now, just imagine, what if I turn these arrows the other way, and the visual field went from here to here, and the disc edema went from here to here photographically? We look at it, I can say, this patient's getting worse. The therapy is not sufficient. More needs to be done. So that's why we don't let these or just send these patients out without offering to help and follow the patient over time. Now, severe progressive vision loss, these are people going blind. They need nerve sheath decompression, where they actually cut open the optic nerve sheath so the cerebrospinal fluid can drain out and not compress the compartment. But that is akin to unbuckling your pants after you've had a big meal. You give more room, but you're still overstuffed. These patients may undergo IV steroids, IV acetazolamide, but most of the time they'll end up with a CSF diversion surgery, such as a lumboperitoneal shunt. And that's going to bring me to polling question number 2. I'm going to start that right now. When encountering florid bilateral disc edema in a 39-year-old obese female, what is the next immediate step? Prescribe Diamox or recommend weight loss, check blood pressure immediately send to an ER, immediately perform an OCT. Now, if anybody is wondering what the background is, that is the Time Church in Prague, Czech Republic. One of the most impressive edifices I've ever encountered in my travels. And I can tell you, at night when the square is lit up, it is absolutely spectacular. If you've never been to Prague, I highly recommend it. It's a wonderful trip. Very good. We're getting through here. All right, I'm going to end the poll. Sharing the results when encountering fluid bilateral disc edema in a 39-year-old. What's the next immediate step? Merely check blood pressure. Very good. I think that's the right thing to do. Send to an ER. As long as you're willing to help, you can get things done expeditiously. OCT, visual fields, photography, all good things to do in your office. I mean, the patient's not going to die in your office. Once they get downstream, it's not going to happen. But one thing you don't want to do is prescribe Diamox and recommend weight loss. You've got to do the tests. I've unfortunately encountered colleagues who have been in this situation. They look at the patient, they presuppose that they have pseudotumor. They don't acknowledge the fact they could have real tumor, and they prescribe medicines. And that is not the right thing to do, because that can be very deleterious to the patient. So remember, not all elevated discs are swollen. Not all swollen discs are edematous, and not all edematous discs are papilledema. True papilledema is an urgency, and we have to look for a cause. We may not have to do it ourselves, but we work with other people to find a cause. Understand, other conditions can present with papilledema, including mass lesions, hydrocephalus, venous sinus thrombosis, and of course, pseudotumor, which is a diagnosis of exclusion. Now, there's a lot of things right there. So I'm going to help you remember it with my ode to a swollen disc. When you think the disc is swollen, the vessels north and south will appear swollen. Not all elevated nerves are edematous, just like not all snakes are venomous. Your thought should go to papilledema, but infection and inflammation should still be in the schema. MRI, MRV, and LP are all soon to be. Remember, pseudotumor is a diagnosis of exclusion. Female and firm does not make it a foregone conclusion. Brain tumors can exist when the pseudotumor profile is classic. So do the evaluation so they don't end in a casket. And if you can remember that, that's about all that you need. I see Carol gave me a nice round of applause. Thank you, Carol. All right, which is better, 1 or 2? Better 1, better 2, better 1. Can I say it again? Yes, no. All right, here are 2 patients who ostensibly have the same diagnosis. One is a distinguished older gentleman. The other is a distinguished middle-aged gentleman. And I want to preface or disclose, nothing on this slide should imply that either Christopher Plummer or George Clooney were ever my patients. I am not saying that. But I'm not saying that either. He's a 48-year-old male who has a painless loss of visual field in his left eye. He's still 20/20, but he knew something was funky when he woke up in the morning. Medical history unremarkable, but he did have a flu about 3 weeks before. This was pre-COVID. We're not going to blame COVID on it. And he has a new, distinct inferior arcuate scotoma. And we take a look, and he's got a hyperemic swollen optic nerve, very small nerve, very crowded, juxtapapillary hemorrhages, telangiectasia of the superficial disc capillaries, and a clear non-arteritic anterior ischemic optic neuropathy. In his right eye, he's got a small nerve. There's virtually no cup. That's just glial tissue. He's got that disc at risk. Now, compare and contrast that to the 74-year-old male who presents with the worst headache of his life. He goes to an emergency room at a Veterans Administration hospital. Over the course of 3 weeks, various visits, he ultimately sees a physician assistant, an emergency department physician, a cardiologist, and a nurse practitioner. Looking at his history over several visits, he complains of eye ache, jaw pain, scalp pain, facial pain, somnolence, to the point he falls asleep while eating his food, malaise, and jaw claudication. Now, at his first visit by a physician assistant, he was diagnosed with temporomandibular joint dysfunction, even though he could fully open his mouth. The ED physician concurred. They prescribed an NSAID and let him go. Doesn't get better, comes back, still feeling very poorly. They find a tick on him. Now he's diagnosed with Lyme disease as well. And throughout this whole 3-week ordeal, he's seen by several people. And in the records, it actually says at several points, vasculitis, such as temporal arteritis, highly unlikely. Somebody writes not GCA, but somebody did order a sed-rate C-reactive protein, which came back elevated, but were never actually reviewed or acted upon. Ultimately, an optometrist makes the diagnosis, and unfortunately, the diagnosis came very late with a very poor outcome. And that's going to bring me to polling question number 3. I'm going to launch that. A 60-year-old patient with a headache presents with a pale, swollen optic disc. What is the best referral? A neuro-ophthalmologist, a hospital ER, an internist, or a retinal specialist? And as you're weighing in, if you want to know that, if you don't recognize that edifice, and I think probably many people would, that's the Chateau Frontenac in Quebec City, Canada, Quebec, Canada. Again, probably one of the most impressive edifices I've ever seen. I think it does beat the Tyne Church, especially when it's nicely lit up, and especially in the wintertime. So if you've never been, we highly recommend it. Okay, we got a lot of responses coming in. People are responding, so I'm going to end the poll. Share the results. A 60-year-old female patient presents with headache and pale swollen optic disc. What's the best referral? I have neuro-ophthalmologist. I have hospital ER. I have internist. Nobody twigs the retinal specialist. I'm going to say you have some good options there, as long as we can get it done quickly. Time is of the essence, and we're talking same day. All are very, very good options. But both these patients have anterior ischemic optic neuropathy. It's a hypoperfusion of the posterior ciliary arterial supply of the prelaminar and laminar and sometimes retrolaminar optic nerve. It may be arteritic, which is immune vasculitis, or non-arteritic, which is more of a ischemic vascular condition. Now, mechanical factors such as atherosclerosis, arterial sclerosis will play a role in the non-arteritic form, while this autoimmune vasculitis will contribute to the arteritic form. It is a unilateral presentation, typically, but a high incidence of subsequent contralateral involvement, especially in arteritic anterior ischemic optic neuropathy. Progression to bilaterality occurs in 65% of patients within 10 days. Whereas in non-arteritic ischemic neuropathy, bilaterality will occur on the order of about 36 months, if it occurs at all. So bilateral presentation of what you think of ischemic neuropathy, we have to consider a widespread autoimmune vasculitis. Optic disc appearance can sometimes be very helpful. Non-arteritic ischemic neuropathies tend to be hyperemic. Part of the optic nerve has been infarcted, so in response, there's a dilatation of the superficial disc capillaries trying to reperfuse the infarcted area. Whereas in arteritic ischemic neuropathies, there is a pale, chalky, swollen optic nerve, and there's a very, very widespread involvement of the ciliary circulation. So there is no telangiectasia, there's no reperfusion. It is typically profound vision loss. Now, in non-arteritic ischemic neuropathies, risk factors can include hypertension, diabetes, atherosclerotic disease, smoking, history of cataract surgery, small optic nerves. 6 to 1, they're going to have an inferior visual field defect. We don't know why it is anatomically that happens, but 6 to 1, it'll be inferior, and it's not an altitudinal defect. It is a glaucoma-like arcuate defect. The nerve will be hyperemic and swollen. They're going to have a disc at risk in that eye and the fellow eye. If a person has a 0.4, 0.5 CD ratio, we should not consider non-arteritic ischemic neuropathies. 98% of patients with non-arteritic ischemic neuropathy have a 0.2 or less CD ratio, and the other 2% have been misdiagnosed. Now, these patients can have a progressive moderate vision loss, not unlike optic neuritis. It can get progressively worse over several days. They're often apoplectic, but there can be progression, and there is potential recovery. There's recovery at 3 months of about 3 lines of letters or more in 60% of patients. It tends to be a little bit of a younger disease. The youngest that I've ever come across has been in the late 30s, happens in the early 40s, and goes all the way up to death. But the critical important diagnosis is painless. It is a painless loss of vision. By the way, if anybody has any questions, you can put them into the chat room, and I will check on that occasionally. Now, arteritic anterior ischemic optic neuropathy has a pale, swollen optic nerve. There may be some hemorrhages, arterial attenuation, cotton wool spots. That is a very ominous sign. Unexplained cotton wool spots in the elderly can very easily be giant cell arteritis. And of course, the retinal capillaries are far too small to be involved. It's most likely platelet microembolization further up the arterial tree. But there's pain of some sort: head pain, jaw pain, shoulder pain, hip pain, back pain, neck pain. It's an uncomfortable, these are people who are often uncomfortable. And there's severe optic nerve dysfunction. The fundus doesn't look all that bad. They can be no light perception, hand motion vision. Visual field defects, if measurable, typically are very similar, and 6-to-1, an inferior defect. Now, giant cell arteritis and polymyalgia rheumatica are risk factors for arteritic ischemic neuropathy. PMR, polymyalgia rheumatica, is always an ominous sign for me. Okay, my population is elderly. I had a unique day. I had 3 patients today who are under the age of 40. That is very atypical where I am in the Venice, Sarasota region. But polymyalgia rheumatica is probably a different end of the same spectrum of giant cell arteritis. Typically, it's in the 70s. The average age of onset is 72 to 73 based upon the studies that you read. It is uncommon under the age of 60, but it does occur. The reality is 50 and above. Once a person is over 50 years old, this disease is always on the menu. And as I mentioned, there's a high risk of bilateral involvement. So we have to do a careful history. We have to ask about the non-visual symptoms. Headache is present in over 90% of patients, and headache arising de novo in the elderly. Even if they have a clean exam, we have to consider this disease. I order sed-rate C-reactive protein platelets very frequently. I probably do it at least twice a week because I have an older person with headache. Scalp tenderness, jaw claudications, almost diagnostic, ear pain, arthralgias, temporal pain, temporal tenderness, malaise, intermittent fevers. These are all findings, signs and symptoms of this disease. Of course, we're going to go through our examination, our lab studies at the very minimum, sed-rate, C-reactive protein, and platelets. Now, sed-rate can be a false negative. It can be lowered by statins. It can be lowered by NSAIDs. A lot of patients are using these medicines. C-reactive protein, an acute phase hepatic protein that is elevated in inflammation, not affected by statins and NSAIDs, and very helpful. And elevated platelet count thrombocytosis is also found commonly in giant cell arteritis. Now, we talked about initial symptoms in GCA, headache. An older person complaining about headache is enough for me to order the proper serology. And I don't do it urgently, but I do it. They can usually get it done that day or within the next day. Polymyalgia rheumatica, chair and stare. It's hard for them to get out of chairs. It's hard to walk upstairs. Now, if you're going to throw in their hair, it hurts when they comb their hair. So chair, stare, hair. And, we used to throw in their fair. We thought this was a disease that really just affected Caucasians. The reason we thought that was because a population study was done in Olmsted County, Minnesota, where most of the population was Caucasian. Thus, giant cell arteritis was considered a Caucasian disease. Now, when the same type of investigation was done in Baltimore, it was split between Caucasians and people of color. So we just can't consider a Caucasian disease. But chair, stare, hair are all things that we can hold on. Fever, visual symptoms without vision loss, transient ischemic attacks, very, very ominous. Intermittent double vision. They may not be diplopic in your office. They may not be ophthalmoparetic in your office, but they have a good, solid history of it happening. And it's mostly due to ischemia to the muscles and not the nerves. Weakness, malaise, fatigue. All right, these are all initial symptoms. Now, there's one thing that these all have in common. Okay? They can have a normal exam. You may look at the patient and everything may, ophthalmically be normal, but they have these symptoms, and that's enough for us to consider looking further for this disease. Now, vision loss, anterior ischemic optic neuropathy, certainly posterior ischemic optic neuropathy, they have a profound vision loss, a normal looking optic nerve, they have premonitory signs of giant cell arteritis, afferent defect, and that's not optic neuritis, that's posterior ischemic optic neuropathy, and that is virtually always going to be giant cell arteritis. About 5% of patients with central retinal artery occlusions have not an emboli, but they have a thrombus. That is due to giant cell arteritis. Transient ischemic attack, what we used to call true amaurosis fugax, that is a premonitory sign, as well as transient diplopia. People who complain of intermittent double vision, any sort of headache, we've really got to consider it. The big ones, TIA, transient vision loss, and transient ophthalmoparesis, that happens about 2 to 4 weeks before they have a profound ischemic event to the optic nerve. So diagnosis, we talked about that. I mentioned down here temporal artery biopsy. Do we really need it? The answer is, well, yes, but I'm gonna qualify that. Once these patients get diagnosed or thought to have the disease, they're put on steroids. They're going to be put on IV steroids. They're going to be put on oral steroids. They're going to be on oral steroids for a very long time. They're going to have complications. Their internist or their rheumatologist will want to get them off of the steroids. Now, if there's a positive biopsy, they have the disease. The internist knows they have the disease. The patient knows they have the disease. Now, here's a caveat. Temporal artery biopsies are beginning to fall a bit by the wayside. Temporal artery ultrasounds are beginning to replace them. And temporal artery ultrasound has actually replaced biopsy in Europe. They don't do biopsies any longer in Europe, to my knowledge. I think they just do ultrasounds. So it's very important to find a vascular surgeon that can do an ultrasound. We have one in our Sarasota area that I work with. Very easy to work with, very easy to get done. So we don't have to have them cut their head open any longer. We can get it done less invasively. When there's vision loss, IV steroids are probably the way to go. They're very effective in preventing second eye involvement. Sometimes they can restore vision in the involved eye. I'm gonna give you. Do I have it here? No. I'm going to tell you what the dosing is. They need 250 milligrams IV Solumedrol every 6 hours for 12 doses. If you want to write that down, sorry, it's not in the handout. I'll give it to you again. 250 milligrams IV solumedrol every 6 hours, inpatient, for 12 doses. Then they're going to be put on 100 to 80 to 100 milligrams, probably about 80 milligrams of oral prednisone upon release from the hospital until they get to under the care of a rheumatologist. And the reason I'm saying this is I deal with this condition fairly frequently, and it's very stereotypical. I will send the patient to the ER with instructions as to what to do. Within several hours, I usually get a call from I give them my cell phone number. I get a call from the ER physician who will give me the results, and then they will ask, what do I do next? They have knowledge, but they don't have confidence or experience. This is where we come in. I will tell the ER physician what needs to be done. Probably 2 hours after that, I'm going to get another call. It's from the hospitalist who's going to admit the patient, who will ask me the same question, the same dosing. What about biopsy? What do I do when I discharge them? They're very thankful for our help when we can give it. Here's a 66-year-old female who has new onset sudden vision loss. She was 2400 previously from a macular scar, long-standing, but she noticed visual field loss for about a day. She had an inferior archroscotoma. Looking at her, she had some disc edema, mild pallor, no hemorrhages, no telangiectasia. Her left eye was a small, crowded disc at risk. The CD was probably less than 0.2. Now, talking to her, she said she had a mild headache. Intermittently, it was relieved by over-the-counter analgesics. She had malaise, a little bit of loss of appetite. She's lost about 7 pounds over the course of 4 weeks. She's got no temporal head pain. She's got no jaw claudication, no double vision, no transient ischemic attack. She's got that disc at risk. She's got an ischemic neuropathy. And I will tell you, she was not a distressed patient. She was what I would call a typical Sarasota suburbanite sitting there in her tennis outfit. And the question is, what do we do? Do we pull the trigger? Do we ascribe this to a non-arteritic? And the answer is, you absolutely have to work these patients up. Her SED rate was 96. I saw her late on a Friday afternoon. By the time I was out having dinner with my wife, I got a call from the emergency physician. The SED rate was elevated, the C-reactive protein was pending, and they asked the question, this looks like temporal arteritis, what do I do next? And we walked them through it. And a couple hours later, I got a call from the hospitalist. Thank you, what do we do next? And we walked them through it. So within about 3 hours, she was in a hospital bed with steroids flowing into her arm, and she maintained her vision. So which is better, one or two? This patient went bilaterally blind from ischemic neuropathy, arteritic ischemic neuropathy that was not diagnosed. This patient had residual field loss, but otherwise was not really bothered. So that's a lot to remember. I'm going to give you my ode to an ischemic nerve. When a patient's optic nerve is ischemic, you better hope the disc is hyperemic. In non-arteritic, no treatment is needed and life is rarely impeded. But the disc is swollen and pale, and vision is an epic fail. If the patient is 60s, 70s, or 80s, you're going to feel heat like you're in 80s. ESR and CRP are required, and steroids must be acquired. Remember, whenever you see a choked disc, always assess the giant cell risk. And if you can remember that, that's going to keep you out of trouble. You like that one, Carol? All right, good. She gave me a thumbs up. 29-year-old female referred for glaucoma evaluation due to suspicious cupping, no complaints, no family history, pressure 12 and 13. And I tell you, when I am now in a large medical surgical practice in Sarasota, Venice, Florida. I do the neuro-op there, mostly because nobody else wants to do it, and I do enjoy it. But when I was at the university in my glaucoma service, I got these referrals all the time. 29 years old, suspicious cupping, 12 and 13 pressure. Am I worried about glaucoma? I am not. My approach is always, I would tell the students and residents, show me a normal OCT and let's go home. So I do an OCT and it comes back so normal. Now I will tell you, I did an undilated look at this nerve and I was not worried about the nerves. I know this patient doesn't have glaucoma, but there is a neurofiber layer defect in the left eye, right? That can be a red disease. It seems to match the ganglion cell complex. Okay, that could be red disease. There's a concordance, but I know this patient doesn't have glaucoma. Okay. So when I'm doing a situation like that, when the OCT does me wrong, I do a visual field. And the visual field comes back abnormal. When the visual field comes back abnormal, I repeat it, and it comes back abnormal again. Now there's a little nasal step. Her other eye, she can do a visual field. She's got a little nasal step that we repeat on the same day, and there it is, and it does seem to match everything. At this point, I know she does not have glaucoma, but I cannot be dismissive of her, so I actually have to go to work. I have to put the clinic jacket back on. I know I'm not going to be home for dinner early. Now I got to get serious and actually examine her. She has 20/15 each eye. She's got normal pressures, thin corneas, gonial is normal, but she has a marked afferent defect in her left eye, which is very unusual considering the relative paucity of structural and functional damage. But she has a very clear nerve fiber layer defect, afferent pupillary defect. So now we take a look at her, we dilate and actually examine her. And, these are the nerves. They were big, deep cups, and that's why she got referred. Well, what I'm going to point out is from 12 o'clock until 2 o'clock or 3 o'clock, it's pale. Okay, she's got a pale nerve. So she's got disc pallor, she's got functional loss, she's got structural loss, and she has optic atrophy. Really, really tough condition to work with. Now, primary optic atrophy, we have nerve fiber degeneration, but there's no architectural alteration of the optic nerve head. The tissue can be pretty white, pretty pale, but the margins are distinct and the retinal vessels are relatively normal. You're going to see this in trauma and compression, such as a tumor. Now, secondary optic atrophy is from pathological chronic disc edema, such as malignant hypertension, papilledema, infiltrative diseases, sarcoidosis, leukemia. Consecutive optic atrophy are degenerative conditions from the retina, retinitis pigmentosa, pathological myopia, central artery occlusion. Here, the disc is going to be pale. It's going to be kind of like waxy. The margins are normal, but the vessels are going to be relatively attenuated. Temporal disc pallor can be if it's unilateral demyelinating disease, old optic neuritis, or if it's bilateral, it can be toxic or nutritional disease. What I'm saying is there's a lot of stuff here. There is a lot to look for. Potential etiologies: infarction, infection, infiltration, inflammation, trauma, toxicity, metabolic dysfunction, mitochondrial dysfunction, compression of the nerve of the chiasm. Now, evaluation, we need MRI of the orbits, chiasm, and brain, with and without contrast. Those are 2 studies. And for the orbit, we need fat suppression, meaning that fat glows white in the orbit. Things that happen to the optic nerve glow white. It's like looking for a snowball in a snowstorm. We have to order it with fat sat or fat suppression. Now, all cases of optic atrophy must be explained or investigated. If you write optic atrophy and you don't commit to an explanation or an evaluation, you might as well write, I think the patient has a brain tumor, but I choose to do nothing about it. Now, sometimes we see patients who have somewhat pale optic nerves. And can we write down optic nerve pallor? Well, we got to be careful. The vision is good, the pupil is good, the color is good, the contrast is good, the visual field is good, the nerve fiber layer is good, it's all good, and it's pale. We might be looking at something that's pseudopal. But pallor with dysfunction is optic atrophy, and we have to do something. Systemic causes include, and this is not a comprehensive list, sarcoidosis, tuberculosis, Behçet's disease, lymphoma, leukemia, lupus, metabolic disease, infectious disease, syphilis, Lyme disease, antiphospholipid antibody syndrome. So at the very least, forgive me doing CBC, SED, ACE, ANA, serum, cardiolipin, homocysteine, B12, folate levels, RPR for syphilis. We got to consider chest x-rays looking for tuberculosis or sarcoidosis. It is an involved workup. Now, what will I do? How far will I go on my own? I will order the imaging. I will do the MRI of the brain and the orbits and chiasm. I don't read films. I look at reports to make sure what was done properly. And if I have a question, I'll contact the radiologist and ask for a reread. After that, when I start ordering serology in a situation like this, I do it with their internists. So I worked with their internist, MRI, the orbits and chiasm, normal brain, normal lesions, working with their internist, lupus panel, ANA, double-stranded DNA, SED rate, metabolic panel, B12 folate, all normal, RPR, HIV, all non-reactive. So what do we do in a situation like that? Follow the patient. She's asymptomatic. 6 months later, her visual field looks like this. I think a year after that, her visual field looked about like that. So if something had happened, we had done our duty in the evaluation, we found no cause, nothing to treat. We admonish her, if anything changes in your vision, come back immediately. Now, next one is a 54-year-old male referred for glaucoma management. He had been diagnosed with glaucoma 6 years earlier in another country, but underwent no treatment. I don't know why. He is 20/30 right eye, hand motion left eye, and his pressure is 30 and 23 in each eye. And we take a look, and he looks like this. And what we see is a large nerve, large CD ratio, probably about a 0.7. But what is really problematic is when we compare the right to the left nerve, we can see the left nerve is relatively pale or comparatively pale. So there's distinct rim pallor to the left nerve. The cupping does not match the vision. And that brings me to our next polling question, number 4. I'm going to launch that. What does this patient most need? Does he need immediate referral to a hospital ER, immediate referral to a neuro-ophthalmologist, non-emergent MRI, the orbits and chiasm, or nothing? This is probably just glaucoma. And if you're wondering where our backdrop is here, it is the lovely Bouchard Gardens in Victoria, British Columbia on Vancouver Island. It is one of the most impressive gardens I've ever seen in my travels. So what?
Hey Joe, I've made it to the webinar. Thanks for getting it started.
No worries, Greg. You missed a good one tonight.
Luckily, we got it recorded. Hey, lean towards your microphone real quick.
All right. You okay?
That's better. Okay. Getting a little too far away.
Now, just that's my partner there. Just shows up. First thing he does is complain.
No, not complaining.
I know. All right, so we're doing real well. So I'm gonna end the poll and share the results. What does the patient most need? Immediately refer to an ER, referral to a neuro-ophthalmologist immediately, non-emergent MRI of orbits and chiasm, or nothing. This is just glaucoma. I think most people have fairly well gotten it, and that is we have to look. So we're going to stop sharing. Did a great job, guys. But let's not forget OCT and visual. OCT was barely abnormal. It was only slightly abnormal in one eye. Visual fields are certainly pretty impressive here. He's got a bitemporal defect. He has essentially a junctional scotoma. It's a large pituitary macroadenoma that is also compressing the posterior aspect of the left optic nerve, and that's what we see right there. And yes, we still need to do visual fields in the age of OCT imaging because sometimes it's not just glaucoma. Here's another patient, 56-year-old female, diagnosed glaucoma 5 years earlier. Complains of slowly progressive vision loss. She's light perception in the right eye, 20/30 in the left eye, had used a combination medicine, had run out several months ago. She comes in, her pressure is 19 and 18, certainly within the realm of possibility. Central corneal thickness is very average, and she looks like this.
Ew.
And what we see here is we have fairly large nerves, fairly thin rim tissue, but a distinctly pale optic nerve, probably more so right than left. And what troubles me in these cases is this bullet point number 3, slowly progressive vision loss. Now, we all know glaucoma is a progressive vision loss, and it's slow, and it's often silent. But these are the patients who notice it a little bit quicker. They've noticed it's been getting worse, much more so than the glaucoma patients. Now, vision is really poor. I could not get a visual field on her right eye, but I did get a visual field in her left eye. And clearly it is a vertical cut, and this is exactly the kind of patient that needs to be imaged. And when imaged, she had a large large pituitary macroadenoma. And the reason I say this, call this a family affair, is, in the initial evaluation and when I brought her back with follow-up to discuss these MRI results, she was with her sister. And as I was describing it to the patient, her sister would add in, she said, "No, I've got something wrong with my pituitary gland as well." I said, "Is it an adenoma?" She said, "Yeah, I've got an adenoma." He said, "I'm using this medication called," I said, "Is it called bromocriptine?" "Yeah, I'm using that." So her sister also had a brain tumor as well, but it was not affecting her visual system. But both of them have compressive optic neuropathy. This is compression from the optic nerve within the orbit at the orbital apex. Orthochiasm, it can be an orbital mass, a tumor mass. Most commonly, it is infiltrated extraocular muscles, Graves' ophthalmopathy. So compressive optic neuropathy, the most common cause is not a tumor, it's actually Graves' disease. And when you have patients who have thyroid dysfunction, it behooves you to look at, if they have any sort of signs or symptoms, to look at neuroimaging. I had a patient with Graves' disease, very mild, but the MRI showed she had posterior compression of her optic nerve, and we had to actually move very quickly on that. So slowly progressive vision loss is the most sinister part of the history for these patients. Now, sometimes the nerve can be initially hyperemic. You will often see disc collaterals. Disc collaterals are beneficial reparative processes trying to reroute blood through a congested area. Visual fields can be consistent with papilledema early disease. Anything happening in the optic nerve can give you a glaucomatous type of appearance. Now, compressive tumors can cause concentric cupping, can make the cup larger concentrically, often with optic atrophy. Glaucoma doesn't do that. Glaucoma causes focal damage. It notches the neuroretinal rim. Nothing notches a nerve like glaucoma. Tumors don't do it. Tumors might cause a concentric enlargement of the cup, deepening of the cavernous atrophy of the optic nerve, but they're not going to notch a nerve. The only thing that notches the nerve really is glaucoma. So to remember how to differentiate these is my ode to a cup disc. Oh, to have a cup disc pink, that, my friend, half the glaucoma is stink. But to have a cup disc pale, call this glaucoma, you shall fail. Disc and field damage is one-sided, simply cannot be abided. It might be trauma, infarct, or meningioma, but if the rim is cut, always remember, nothing notches a nerve like glaucoma. So if Carol likes that one too. So if you've got a notched nerve that's not pale, you've got glaucoma. If you've got a cup nerve that's pale, you got something else. And if you've got a notched nerve that's also pale, you've got glaucoma and something else. I'm going to take a look. I don't see anything in the chat. Greg, it's been very quiet. Maybe the chat box been turned off. Been very quiet tonight. So here's a patient, 42-year-old female, sudden painless loss of vision, left eye for a week. Getting worse, not getting better. It began as a dimming, then it rapidly dropped off. She's 20/20, 2400. She has a mild afferent defect, which I think is very pertinent considering the severity of her vision loss. Confrontation fields are full peripherally. Amsler grid, she's got a central scotoma in the left eye. Biomicroscopy, she's normal. Pressures are normal. Her optic nerve is not normal. We have a unilateral neuropathy. We can see obliteration of virtually the optic nerve. We see an accumulation of exudate in Henle's layer pointing to the optic, to the macula. And we call that, the macular star or the partial macular star. Now, she has no known HIV risk factors per her. Recent illness, she had a severe flu with malaise, fever, and lymphadenopathy about 4 weeks earlier. This was pre-COVID, so we're not going to blame COVID. She has no tick bites, no rashes, but she does have cats. She is exposed to cats. Serologically, she's got, we test for FTABS, RPR for syphilis, HIV, Lyme, toxoplasmosis, toxocariasis, purified protein derivative, all negative, but Bartonella henselae titers come back positive, and she is diagnosed with cat scratch neuroretinitis. Or more broadly, she has infectious optic neuropathy. I probably have to consider this condition once a month or at least once every other month. Now, there are many things that can cause, many infections, many things can cause infectious optic neuropathy. Syphilis, it can give you a retrobulbar, a bulbar neuropathy, a neuroretinitis, or a perineuritis. What is perineuritis? The optic nerve is edematous. It is typically unilateral, but the visual function is good. Retrobulbar and bulbar have severe vision reduction. As I said, perineuritis has normal vision. The MRI, the coronal view of the MRI is going to show enhancement of the optic nerve sheath. The optic nerve is fine. It's the optic nerve sheath that's involved. That's almost always infectious and is almost always syphilitic. Lyme disease mimics syphilitic optic neuropathy. Anything syphilis does, Lyme can do better, vice versa. They're both spirochetal bacteria. One is Borrelia burgdorferi, the other is Treponema pallidum. They are so similar, they can actually cross-react. A patient with Lyme can test positive for syphilis. A patient with syphilis can test positive for Lyme. Syphilis obviously is a sexually transmitted disease. Lyme disease is a bite of a mammalian deer tick. People who are around deer, large mammals, spend time in the woods, close contact hunters, they can get bit by these ticks in endemic areas, and they get Lyme disease. Now, toxoplasmosis, HIV infection, cytomegalovirus, destructive to vision. Neuroretinitis is typically a benign lymphoreticulosis, as I just described, cat scratch disease. Very important is the APD is relatively mild compared to the vision loss. And that tells us this is more retinitis than it is neuritis. Even though that it looks horribly optic nerve, it is more retina involved. The macular star is a relatively late finding. It usually takes about 2 weeks to show up. But what is very characteristic in these unilateral disc edema cases is there is a serous detachment from the disc to the macula. Not fluid, not cystoid macular edema, not macular detachment. It will split everything from the disc to about the macula. So we don't have the exudate, but this can still be neuroretinitis. Nice example, patient, 62-year-old female who's been diagnosed with strep throat on antibiotics for a day, complains of count fingers vision in the right eye, very poor vision, very mild relative afferent defect. We see this is probably relatively early in the onset, a very, very edematous optic nerve, no exudation, no macular star, but what we see here, we get out the OCT, it's not fluid, it's a detachment from the disc to the macula. If you see that, you're dealing with an infection. So neuroretinitis and infectious optic neuropathy have many potential etiologies. Toxoplasmosis, toxocariasis, measles, syphilis, Lyme disease, herpetic disease, mumps, tuberculosis, malignant hypertension, ischemic neuropathy, leptospirosis, Bartonella, most common. Fleas are the vectors, so you don't really have to have a cat scratch. I see a question came in. Can mono cause this too? The answer is yes. So prognosis is for vision recovery is excellent if it's cat scratch disease. Many of these patients are going to return to normal with or without treatment. Antimicrobial therapy has been used to hasten recovery. Rifampin, ciprofloxacin, doxycycline. Doxycycline 100 milligrams, by mouth for a month is going to work well. These patients sometimes get injected with avastin because there is elevation of the macula. It's what retinal specialists do. There is really there's no study that shows any of these treatments are better. You certainly don't want to use steroids on patients if you don't know the cause. And this is all predicated on the understanding that we're dealing with Bartonella, Quintana, or Hensley, and it's cat scratch neuroretinitis. If it's any of these other diseases that we have up here, they have to be treated. That's why when I am dealing with suspected infectious optic neuropathy, I will go order imaging of the orbiting chiasm, but I am going to work with a primary care physician. I will tell him or her what tests to order. I will even write up the order, give them the orders, because if there's something that comes back abnormal, they're going to be primed to deal with it. They don't know what to order. They like the help. I always work with primary care physicians, and it works out very well. If you do have neuroretinitis and this cat scratch disease, you want to do something, any course of any oral antibiotic that you like is going to be as good as anything else. Doxycycline, Keflex, dicloxacillin, whatever you want to use. A Z-Pak, it's all going to be the same. It may hasten the recovery. It should be a good outcome. Now, there's a heck of a lot to remember. So I'm going to leave you with what I call my ode to infected nerve. When the vision is poor and the APD mild, it's often the bite of something wild. If the disc is swollen and the macular swelling great, it's neuroretinitis, and the star comes late. Syphilis and Lyme are much alike and can cause similar titers to spike. One is sexually transmitted, the other not, unless the patient's weirder than you thought. So that's all you have to, Carol really likes that one. All right. Anything in the chat room? We're good. We're clear.
Yeah, the question, Joe, about, can mono cause it? Just a reminder to everyone, mono is usually related to the Epstein-Barr virus, which is in a sense a herpes virus. And Joe mentioned herpes simplex and, herpes zoster. So remember the Epstein-Barr, it's considered the human herpes virus number 4. So that's why that's the correlation there. Just FYI to people.
All right. Anything else, Greg? That was an excellent comment. I don't see
That
anything
was
else in the chat room.
nothing else in the chat room. So
All right. 48-year-old female who complains of sudden vision loss in the right eye. Saw this patient probably within about the last 2 months. I've actually seen her in follow-up. So she had sudden vision loss in the right eye of about 2 days duration. Now, she went to an ER and she had a CT of the head without contrast, which was normal. And why was that? It's what they do. And, I'm actually not sure if she went to the ER or if her primary care physician, who was a nurse practitioner, and, at least in my area, a lot of the primary care physicians are physician assistants and nurse practitioners. I really enjoy working with them. I think they're very sharp and they're very aggressive with taking care of patients. So and she had a CT of the head, which was normal, and she was diagnosed with zoster because she had some head pain. Now, she was given a prescription for Valtrex and prednisone, and she is referred to rule out ophthalmicus, zoster ophthalmicus. Greg, you have that happen all the time, right?
once a week.
Yeah. Primary care physicians make a good diagnosis of herpes zoster, shingles. They know what to do, but they always want us to give the blessing that there's no ocular involvement. If there's ocular involvement, we know what to do. So she comes to me and she said, she hasn't used the Valtrex and prednisone because she doesn't really think she has zoster. Now, interestingly, she's got 20/60 acuity in the right eye, 20/20 in the other eye. She has an afferent defect. That's not going to, you're not going to be getting, I don't know about zoster in that situation. Color vision, she was 14 out of 14 in each eye, but she had a struggle in her right eye, and she has retroorbital and temporal pain. Now, examined, she has no vesicular skin lesions, no rashes, 20/60 acuity, just a little bit of trouble with color, head pain, and she looks like this. Relatively small optic nerves, modest cupping, there's no swelling, there's no pallor. In fact, they look to me to be perfectly normal. Visual field analysis, she has a normal field in her left eye, and she has the inferior arcuate scotoma beginning in her right eye. That brings me to my next polling question, number 5. I'm just going to launch that. Oh, did you get it, Greg?
Yep, I got it for you.
Okay,
And
thank
Joe,
you.
and the comment that it happening once a week is we know that these herpes viruses, especially zoster, at least the primary care, the physician assistants, they know that it can cause anything from a keratitis to a uveitis to a retinitis to an optic neuritis. And so they know that that's the leading cause of vision loss, or corneal vision loss in the United States. So a lot of times they come in on appropriate treatment. So, not kidding, it's probably once a week or, maybe once every other week would be the longest that someone's coming in appropriately diagnosed. But what they want is a good exam, making sure that the front, middle, and back of the eye is okay, including the optic nerve, and a report back. So I think some of our colleagues get frustrated with that. Why are they sending it to me? It's already diagnosed and treated, because they know that the eye can be involved in many areas.
So what testing should be done in this patient? MRB, MRA, MRI, brain with and without contrast, MRI orbs and chiasm with and without contrast. I think we know what this backdrop is. This is a Rolling Stones concert when I saw them in Miami. This was a few tours ago. You can tell because Mick Jagger looks still very young and handsome there. And if I focus well enough, you can actually see the set list there. So I got very close enough to tell you he doesn't have any hair visible on his body anywhere that you can see. All right, doing all right. We still got people with us. I guess for the sake of time, I'm gonna end this. We're gonna end the poll. I'll share the results. Okay, we have MRV, MRA, MRI brain without contrast, MRI orbits and chiasm with and without contrast with fat suppression. Really, the last two are both very important in a case like this because we probably have a pretty good suspicion. And that's going to bring me now to the next polling question. You want me to get that, Greg, or do you have that? What's the most likely diagnosis? Optic nerve infection, infiltrative optic neuropathy, compressive optic neuropathy, demyelinating optic neuropathy, or I don't know, zoster seems pretty good to me. And that backdrop is the Grand Canyon.
Is that taken from a plane, helicopter, or is you just taking that from a mountaintop?
Just from the ridge.
Yeah. Cool.
And the rim. You know, there's this great family legend in my wife's family where her brother claimed, or the family claims that he when he was training for football filled a backpack full of rocks and ran from the bottom to the top. And remarkably, people seem to believe this, but of course, that's physically impossible. That's a several day journey that people die from. All right, so let's end the poll and share the results. So it looks like the lead here is the demyelinating optic neuropathy, and that's certainly something that we have to consider in this situation. So I did order the tests in the MRI, the orbits, enhancement of both optic nerves and optic nerve thickening, worse on the right, suspicious for optic neuritis. MRI brain, extensive non-enhancing punctate, foci of abnormal prolongation, raising possibility demyelination with optic neuritis. So that's what her diagnosis was. Her primary care physician was very thankful that I found this and told her not to take the oral steroids because we know that could be somewhat deleterious, though a med-roll dose pack probably would have hurt the patient. But she had demyelinating optic neuritis. This is a focal inflammatory demyelinating event of the optic nerve. It can be idiopathic and involving only the optic nerve, associated with other systemic illnesses, including multiple sclerosis. Now, I don't like using the term optic neuritis for the variety of infectious diseases or infiltrative diseases. When I say optic neuritis, I think our implication is or should be demyelinating disease, either the spectrum disorders of neuromyelitis optica or optic neuritis and multiple sclerosis. About a third are papillitis, 2/3 are retrobulbar. The optic nerve looks fine. There is an abrupt vision loss on average from the ONTT is about 20/60. You can certainly go quite a bit worse. There is a relative afferent defect. There is a dyschromatopsia. There's a decreased brightness sensitivity, decreased contrast ability. And it usually has a nadir of about 2 weeks where it gets progressively worse. With gradual recovery, though, there are some deficits in brightness sensitivity, contrast sensitivity. There'll always be, usually always be an afferent defect. And pain. 92% of these patients have pain, and it's usually retrobulbar and pain with eye movement because of concurrent inflammation of the optic nerve sheath. My experience on these patients, the number one symptom is pain. Number two symptom is dyschromatopsia. There is a lot of hardware that goes into color perception. That's why it tends to go first. Vision loss, it might be on a 20/25 level. That isn't usually initially the complaint for some of these patients. It's the pain and the dyschromatopsia. MRI is going to be critical in diagnosis and management of these patients. The optic neuritis treatment trial, their 15-year results. Conversion to clinically definite multiple sclerosis happened in about 50% of patients overall. Now, if they had a normal MRI at baseline, now keep in mind, you can do an MRI and it may not be definitive. If they had a normal MRI at baseline, only about 25% of patients progressed to clinically definite multiple sclerosis. And if they had an abnormal MRI, as this patient did, there's about a 75% conversion to clinically definite multiple sclerosis. And there are a number of questions that we have to, we're going to get asked, and whether or not we answer. The question is this optic neuritis? Well, the question, the answer could be yes in a patient. Is there evidence of demyelinating lesions? The answer is yes. Now, the patient asked, do I have multiple sclerosis? That's nothing that I feel comfortable to answer. I know neuro-ophthalmologists that won't make that diagnosis. They want that diagnosis actually made by a neurologist specifically skilled in demyelinating disease. Now, the lowest risk of conversion to clinically definite multiple sclerosis were males, those who had a papillitis, those who didn't have pain, and those who were no light perception. This was the optic neuritis treatment trial. And what is characteristic, particularly the last two, some of these, they probably didn't have optic neuritis. They were in this study, but they were probably misdiagnosed. Now, question from Gene, is Ishihara red-green color test appropriate, or must be the other color? No, Ishihara is fine. That's fine. Red cap sensitivity. What color is my tie? What color is my shirt? What color is my shoes? These are all things that can tell you there's dyschromatopsia, and that's more important than 6 out of 14 plates. Now, if they had a normal MRI baseline and no clinically definite multiple sclerosis at 10 years, then they only have about a 2% risk at 15 years of developing MS. Now, back in, do we rush to make a diagnosis, or do we defer? When I was early training in my career, the attitude was don't ask, don't tell. Meaning that we would work a patient up. We suspected optic neuritis, but we would stop short of making that diagnosis. We might get a CT scan to make sure there's nothing else, but we would hesitate to use the term optic neuritis because there's no treatment. And the philosophy was, why rush to a fire if there's no hoses to put it out? Well, that's no longer the case. Now we've gone from this don't ask, don't tell to get the patient in the healthcare system in the hands of a skilled neurologist as quickly as we can. There are now interferon therapies, betaseron, Capaxone, Avonex, that significantly slows the accumulation of neurologic disability. So there is actually a penalty now for not starting immunomodulatory therapy early in the disease, or at least at onset. So we used to avoid making the diagnosis because we had no way to modify the disease. Now there are modifications, therapies that will do that. So we've gone from don't ask, don't tell to get them in the system as quickly as we can. Now, I'm going to give you a disclosure. You may have picked this up by now. If I didn't mention it before, I'm going to mention it now. Optic nerve disease often doesn't end well. Just so you know, it often doesn't end well. And it's through no fault of our own. It's just a very fragile system. She's a 72-year-old female who has new onset flashing lights. Not sure if it's both eyes or just the right. No floaters, but flashes. She's 20/20 each eye. Pupils are normal. Confrontation fields are full. She has a multifocal IOL. She has asthma, hyperlipidemia. She uses Valtrex, prophylactic old infection. And she was seen by one of my colleagues at Center for Sight, who goes in expecting to look for PVD and vitreoretinal traction, and actually comes across this by accident. So she has a normal optic nerve in the left eye, and she has a markedly edematous optic nerve in the right. Hint, she has been to a Lyme endemic area. Now, this is what she looks like. Her visual field is essentially normal, maybe a borderline in the right eye. Her optic, her macular scans are perfectly fine. There's no fluid there. There's no serous detachment of the macula. She just has a relatively asymptomatic swollen optic nerve with good vision. And that brings me to polling question number 7. What is the most likely diagnosis? A compressive tumor, infectious optic neuropathy, ischemic optic neuropathy, and giant cell arteritis, infiltrative optic neuropathy, a CRVO variant, or I don't know, that's why I'm here. And if you don't recognize the background here, this little harbor town, that's Auckland, New Zealand. So what's the most likely diagnosis? Compressive tumor, infectious neuropathy, ischemic neuropathy, and temporal arteritis, infiltrative neuropathy, some sort of CRVO variant, or I don't know, that's why I'm here.
So while your polling questions rolling in here, Joe, I've built a nice little immunology review that maybe we'll turn into a lecture here one night. But in doing immunology, you have your blood neurology, but then also you have your brain neurology that's out there. And you have monocytes, which we kind of talked about being in the blood, but then it's macrophages when it gets into the interstitial fluid. But of the brain, the special macrophage or the microglia. So if you guys want to do a little light reading at some time, read about the microglia, which are the macrophages of the neuroimmune system. And that's been tied in pretty heavily to demyelinating disease. So a little bit of FYI for you guys there, but a little bit of light reading for you.
Okay, so we have a little bit of a lead for infectious optic neuropathy, followed by, I don't know, that's why I'm here, which is a good answer. Some ischemic, infiltrative, a variant, compressive tumor. All right, well, we can tell she has an optic neuropathy. She's got good vision, good visual function. She is otherwise asymptomatic, except for maybe some flashing lights, which may or may not be pertinent. So presumptive diagnosis for me, infectious optic perineuritis. Remember I said swollen nerve, good visual function. MRI brain and orbits and chiasm with contrast and fat suppression. Fat suppression is only for the orbits, MRI brain with without contrast, MRI orbits with and without contrast, and fat suppression. Normal. I was very surprised. I was expecting to see optic nerve sheath enhancement. So I go back, I asked for neuroradiology, reread, specifically look at the optic nerve sheath, looking for enlargement and perineuritis, because it's got to be Lyme disease. Still normal. Okay, now I work with the PCP, and we go on to serology. And what do we order? CBC, SED-rate, CRP, ANA, RPR, FTABS, ACE, Zoster, IgM, and IgG, Rubella, IgG, IgM Toxol, Lyme, Bartonella, and Hensley, Quintana. And you can write all of this down, and you can use this in the future. You know, the internist here is a very lovely man. He said, you know, we talked about it. He said, yeah, I've heard something, I think it starts with a T, right? So yeah, toxoplasmosis. So I know what to order. He knows how to interpret. We worked together. Everything came back essentially normal. except some that indicates she may have had an old Epstein-Barr infection, which she recalled the fatigue several years earlier. She has an old infection of HSV. We all know this. It was all non-contributory. After all of this, and she asked, "Is there anything you didn't test me for?" I said, "Yeah, the West African variant of the Nile virus. I didn't test you for yet." So, we watch her, and what happens, unfortunately, 2 months later, she's still 20/20, but we see she has developed a pretty significant visual field defect. 4 months later, which was actually last week when I saw her, her optic nerve swelling has dissipated. And what do we see? She is still left with optic disc pallor. Her visual field defect has improved a little bit, but that's pretty much there to stay. I don't expect it to get worse. I don't expect the other eye to be involved. A fair outcome only. We did everything we could, couldn't find anything. And I think I'm going to wrap up with this last quick case, a 36-year-old male, sudden painless loss of vision of 1 day duration. This was actually my wife's patient that I helped her with. He is 20/20 in the right eye, 2200 in the left eye. There's a relative afferent pupillary defect in the left eye. He's a type 2 diabetic. He's on metformin. We can see what his visual fields look like. And here are his optic nerve, or his fundus appearance. And we can see he has diabetic retinopathy going on. He has got quite a bit of swelling in the macula. He has got a little bit of a serous detachment there along with fluid. What else we see? He has a markedly engorged optic nerve. And that's nothing that you're going to see typically in a patient with diabetes. So he has diabetes, diabetic retinopathy. He's got diabetic macular edema, and he has quite a bit of some separation in there. Maybe this is an early neuroretinitis, infectious disease here going on, but he certainly has optic neuropathy on top of that. But our differential diagnosis includes infection, infiltration, inflammation, demyelinization, compression. So our evaluation has to occur, and keep this for reference. This is pretty encompassing. MRI brain with and without contrast, MRI orbits and chiasm with contrast, without contrast, and fat suppression. Needs a CBC, ESR, CRP, ANA, RPR, FTABS, ACE, zoster, rubella titers, toxoplasmosis, Lyme, Bartonella, Hensley, and Quintana, P. ANCA, C. ANCA, looking for vasculitides. And of course, he's got diabetic retinopathy. He needs to see one of our retinal specialists. Now, I helped my wife with the ordering of the test and recommendation. She also sent the patient to our retinal specialist for the diabetic aspect. By the time he got to the retinologist, which was about 2 weeks later, he had not obtained any of the imaging or any of the serology. So our retinal specialist sent him right to the ER with directions and recommendations for a full evaluation because he had not followed through with it. Gets to the ER, sees the on-call ophthalmologist, who may have actually been a resident, who examined the patient and said, did a CBC, you don't need an MRI, you just got diabetes, which is, pretty insulting to our retinal specialist who referred me. What you think, if it was just diabetes and diabetic retinopathy, he could probably have handled that. So ultimately, the patient went through everything. We did capture the patient back, get all the testing done, and again, everything came out normal. So he has undergone anti-VEGF injections for his diabetic macular edema. When I last looked at the chart, the disc was still swollen, but his vision actually improved to about 20/50 from treatment. So with that, I think that we're about at the end. I don't think we have anybody else in the chat room. It is really quite exhausting trying to exhausting coverage of all the neuropathies that we commonly see. There's many other things out there. Hopefully this talk, excuse me, was beneficial in getting you primed as to what to think on these common neuropathies. So Greg, I'm going to see if there's anything you want to add in here, or anything you want to share here.
No, I'm good. I'm gonna let someone in right now. No, sorry I missed the first half. Thanks for doing
No
this.
worries,
And
no worries. I'm just going to share back again our housekeeping. So this was clinical rounds and optic neuropathies. You've got some nerve. It was a distance learning course. I enjoyed talking about this material. I see these patients frequently in our practice. I'm the one who's been doing the neuro op since I've gotten there. One of our retinal specialists used to do it against his will. He now sends the patients to me, and as I learn things and discover things, I like to share it with my colleagues. All right.